Well, welcome everybody to our third Venous and Lymphatic Journal Club, sponsored by Tactile Medical. I'd like to thank everybody for participating and joining us today. Like I said, this is our third one, and we've had pretty good response from them so far. And we hope you're going to enjoy today's three articles that we have. And to kick off the meeting tonight, I'd like to put up a poll question. Who is actually the founder of the first journal club? Is it Sir William Osler, James Paget, Rudolf Virchow, or Jonathan Mueller? Johansen Mueller. Well, let me ask our esteemed here colleagues, Dr. O'Donnell.
Well, it's got to be someone who had something to do with the lymphatics. So I would pick Virchow, who's surgeon pathologist.
But in general, all journal clubs, not just vascular.
Oh, I would imagine then. Sorry, I would imagine it might be Sir William Osler.
Okay, Tom.
I mean, Steve.
Sorry.
Just to be different, I'll say James Paget. I have no idea.
Well, our audience, Sir William Osler. Actually, the correct answer, the first journal club was reported in the mid-1800s, and it was James Paget.
Ooh,
Thank you.
Steve.
Thank you.
And actually, Sir William Osler was in Europe, of course, in UK. William Osler actually did the first journal club in Montreal, so in the Americas, and the story is from a Paget perspective. The story is that they used to do the journal clubs right across from the university and upstairs in a little apartment above a bakery. And not only did they review journals, but they also played cards. So maybe we can have a card game at one of these journal clubs that we have. Sir William Osler, the reason they were doing journal clubs, or they started doing them, is because they couldn't afford to buy the journals, so they would distribute to the students and residents or whatever the journals for them to review. So, so Paget it is. And for today, we have three great papers dealing with venous and lymphatic disease. And Dr. O'Donnell is going to talk to us about how lymphatic anatomy and function degrades in patients with early venous insufficiency. Then Steve is going to discuss indocyanine green lymphangography findings in patients as they get older with lower extremity lymphedema. And then I'm going to finish off with a paper by Tom Maldonado on assessment of quality of life in patients with lower extremity lymphedema before and after use of an advanced pneumatic compression pump. So with that, I'd like to get Dr. O'Donnell to share his slides.
Well, I'm going to say a few words before I zip into my presentation. Just from the Tactile team, I'd like to welcome you and thank you. One of the things that we hope you will do is there's a post-presentation survey. Please fill it out. Please be sure that you don't hold back. We've had several very important comments like, please keep the dog out of it. that was one comment, but we'd like you to sort of tell us what you would like to see in future journal clubs. My task tonight is to talk about how the lymphatic anatomy and function may degrade in the earlier phases of venous insufficiency.
Hey, Tom, before you go to the next slide, just want to make sure everybody, any questions or comments or anything, please share them in the Q&A box at the bottom, and we'll, interrupt the speaker and ask the questions as we go along if we need to. Go ahead, Tom. Sorry.
Thanks, Tony. And this is from the work in conjunction with the team in Houston, Eva Sevick and John Rasmussen, who are well published in this field. These are my disclosures. I do work as the Chief Medical Officer for Tactile Medical. Now, the purposes of this study was that it was a pilot study, and we aimed to define normal and potentially abnormal values for NERFLI. We wanted to assess the lymphatics in the pre-advanced chronic venous insufficiency stage of chronic venous insufficiency and determine whether involvement and/or degradation of lymphatic anatomy or function could play a role in the progression of CVI. This is the schema one uses as the agent, indocyanine green. I'm old enough to have used this to do cardiac outputs before there were thermal dilution in the intensive care unit. The device is a imaging apparatus based on military night goggle vision, and it gives you really unprecedented non-invasive imaging sensitivity through very deep depths compared to the next technique, which will be discussed by Steve. This just gives you an example. One uses a intradermal injection, just the same way you would do for TB, shown here in the foot, and then the dye traverses up the lymphatic trunks. We previously presented patients with venous ulcers and determined how the sequential pneumatic compression pump might affect lymphatic function. In that study, a consistent finding as far as the disease was bilateral dermal backflow. And this proprietary advanced pneumatic compression device produced proximal flow of the dye, representing proximal flow of lymphatic fluid. It recruited new lymphatic vessels, and as it compressed, it emptied the distal lymphatic vessels. We wanted then to turn, as I said, to patients with less severe non-ulcer chronic venous insufficiency. 10 patients were enrolled with 20 limbs, and they were compared to 9 with no venous disease. As far as the demographics, the age was 53 for the CVI, and the normal patients were slightly younger. What is consistent with all the studies that you're going to see on lymphedema and venous disease, these patients were in the obese category compared to the normal subjects. Now, the parameters that are used as far as describing normal, abnormal is the anatomic structure, the injection-associated backflow, which is described in an area of square centimeters, proximal dermal backflow, again in the area of centimeters square, and then the propulsion rate in events per minute while in the supine position, standing, and then post-exercise. Now, these are an example of normal architecture. You can see the well-formed linear lymphatic trunks with pulsatile unidirectional flow from the injection sites toward the regional node basins. This is the calf. Obviously, this is the thigh, but you'll notice they're very well defined. By contrast, when you enter the disease states, and we have an example of patients with mild venous disease, C2, there's unusual lymphatic drainage patterns. These are not typical. And early signs of dilation and segmentation of the vessel. It looks like a sausage, and there's segmentation here. When you get to C3, there's distinct segmentation shown in this limb here. In C5, it's a little blurry, and it's segmented again, and the vessels are dilated with dermal backflow around the ankle injection site. These are all. Yeah.
Can you explain to the audience what you mean by dermal backflow? Like what exactly is going on?
That is reflux of dye back into the very superficial lymphatics of skin and dermis. So the dye represents the lymph fluid back under pressure, going backwards rather than forward, indicating there's obviously disease in the lymphatics. Now, there are several criteria, objective and quantitative. One is, as Tony mentioned, dermal backflow and interstitial backflow is a very important finding. And the way it's computed is the number of abnormal injection sites over the number of total injections. And the normal has a value of 0.46%, i.e., there's very minimal abnormal sites. By contrast, as you go up the disease severity, C3 has a value of 25%, obviously significantly different than the normal, progressing up to C4 and then C5. All of these are different than normal, but only C3 is different from C5, and that's probably limited by the small number of patients. As the number would get greater, you might see better discriminatory values. Now, one of the unique things that most people don't appreciate is the active lymphatic propulsion of the lymphangio, as shown in this diagram. There are valves, and the smooth muscle within the lymphatic vessel causes contraction. So that's been used to compute the propulsion rate for each limb in these patients, the supine position and standing position. And with that, one can ascribe normal values to that in the number of beats per minute, if you will, versus the abnormal. Architecture findings are really important in a qualitative way. Interstitial backflow near the injection sites is the earliest sign of reduced lymphatic uptake. Probably indicates higher clinically indistinguishable interstitial fluid volumes and pressure, which forces intradermally the injected boluses to spread throughout the skin before lymphatic uptake. Again, evidence of increased pressure within the lymphatic. Answering Tony's question, what is dermal backflow? The lymph abnormally backfills the capillary lymphatic network and is usually not observed in normal subjects.
So you first develop interstitial backflow and then you start seeing dermal backflow as disease progresses?
No, you see it, dermal backflow, you just anticipated one of my questions. Dermal backflow is the first sign that you would see.
Okay.
And then this is common in pre-symptomatic and early stages of lymphedema. Now, what is of the following is not a diagnostic measure for NERFLY? The audience can respond. Megan, are we getting them? Well, I would say that half of the audience is right. It's the intensity of the indocyanine green image. Next question. What is the most sensitive criterion on NERFLY for early change in the lymphatics with CVI? Is it interstitial backflow, dermal backflow, vessel segmentation, dilation, or unusual drainage patterns?
Sorry for ruining that.
Well, I may have a surprise. I may have a surprise for you, Tony. Dermal backflow, swayed by Dr. Gasparis' question. It's actually interstitial backflow. I fooled you, Tony. Sorry to the audience. So the conclusions of this pilot study is lymphatic anatomy and function generally degrade with the severity of chronic venous insufficiency. And a question that intrigued my co-panelist, Dr. Dean, is lymphatic insufficiency causative or a result of chronic venous insufficiency? Or alternatively, does it develop from other mechanisms which remain to be elucidated? I think one of the important things, if we're going to use this as a test from this pilot study, is that it provides normal values for NERFLY to which values from diseased limbs can be compared. And it suggests that this provides good evidence that we ought to treat patients with C3 disease earlier for the management of edema to prevent the consequences of edema within the lymph. Thank you. We're open for questions.
Okay, Tom, well, yeah, back to my question I had for you. I thought it was an interesting comment in the paper. I mean, why wouldn't you think that the lymphatic insufficiency is a result of the venous insufficiency? I mean, why would you think otherwise? I mean,
well, it is, but the lymphatics can play an independent role. Actually, in the next, this is a plug for the next seminar, Eva Sevic will present some data that shows staining of vein tissues with varicose veins. These tend to have a diminished number of lymphatic vessels than control veins. And so one wonders if perhaps an initial degradation of the vein draining lymphatics may lead to vein wall inflammation, which, if unresolved, could potentially promote broader venous disease. So this is turning the card around and saying, well, maybe the lymphatics play a role. And indeed, there was done in Japan a rat experiment where they ligated the lymphatics to around the femoral vein, the perivenous lymphatics. And over time, lipid accumulated and there was degeneration of the venous tissue, suggesting that lymphatic abnormalities can promote associated chronic venous disease.
So, Tom, one of the audience participants is asking, can a CLT tell the difference between interstitial or dermal backflow? Or is it only found on imaging?
What's CLT?
Complex lymphedema therapy, I guess.
Oh, yeah. Well, that's a very good question. And I know we have a lot of therapists here. Actually, people are using this to direct the areas for the immunolymphatic drainage. And you'll see that the dermal backflow improves with immunolymphatic drainage. So it's really Icg-directed immunolymphatic drainage.
So another person's asking, as far as what you're describing, what is meant when Tactile says the pump can recruit new lymph vessels?
What it can do is, as it mobilizes and stimulates the lymphatic trunks, you only see, just like lymphangography or lymphocentigram, you only see the vessels that have either radionuclide in it, the dye that you use in lymphangiogram, and here the indocyanine green, they're recruited as more vessels are opened up and lymph is propelled from. The mechanism, as you know, of FlexiTouch is different. It's not a squeeze and hold. It's stimulating lightly the lymphatic trunks analogous to manual lymphatic drainage. So it recruits those lymphatic vessels that previously were dormant and not having lymph flow through them.
So I know we've talked about in the past that, as when this becomes available to use, looking at patients with early venous disease and see if they have any, improvement in their flow before and after treatment of the lymphatics, or maybe even before and after use of any type of therapy, including, a FlexiTouch. Right,
and you're going to be doing that study because you're going to have one of these at your institution.
We hope so, yeah.
Well, no, you are.
Oh, someone's asking if I was interested in performing this test, how expensive is the equipment and what's the learning curve in learning how to use it or interpret the data?
The market price hasn't been set yet, but it is in the commercial phase now. They're being built. And I don't think it's the hardest part, from what I've been told, is perfecting the intradermal injection, just like you would do for a TB test. That's where people stray. They may give the injection too deep.
But how about interpreting the images and stuff?
Well, that's the purpose of this, is that with the area and intensity, it will be able to be quantified by using software.
Gotcha.
And certainly the propulsion rate will also be able to quantify.
Yeah. Well, it'll be interesting. Do they have, I mean, off topic, but do you know if they have reimbursement for this, if it's, let's say, available in the office?
It's currently reimbursed, yes. And obviously, the breast cancer surgeons and radiotherapists in the audience, the breast cancer surgeons, uses a form of indocyanine green for mapping prior to and during surgery, but it is reimbursed.
Oh. All right.
I can't talk prices.
No, just curious.
But it's not far from an ultrasound.
This will definitely be a great tool, not only from a research perspective, but it will help answer a lot of the questions which we kind of, have theories on, but no real great data to support,
Well, you're right. One of the questions I have is, how often is lymphocentigraphy used in the diagnosis of lymphedema? And currently, we're part of a survey that we're doing, actually a medical claims data analysis. We're going to look at that. My impression is lymphocentigraphy is used infrequently in clinics which are very experienced with lymphedema. It's used more just to confirm the diagnosis when there's doubt.
Well, you got Steve and I going down, so.
Yeah, very well stated.
Yeah. All right.
Thank you.
Let me see. I think all right, so we'll have Steve share your screen.
Okay, if you're ready,
You're up next, Steve.
I'm ready to share here. All right. Okay, can you see that okay, Tony?
Yes.
Right.
Okay, so you see my article here is entitled Indocyanine Green Lymphography, or Icgl Findings in Older Patients with Lower Limb Lymphedema. This is from Dr. Yoshida and Associates from Japan. This was published just last year in the Journal of Vascular Surgery. There's my disclosures. And we're going to start right into a poll question. Question 1. Lymphedema tarda typically has a higher lower extremity lymphedema index than age-related, the unwoke term would be senile lymphedema. Is this true or false? Good. We can see who read the article. Well, it's flip of the coin. That's not bad odds. But majority of you got this correct. It's actually true. All right, let's go on to our next question. A little bit more complex. Age-related or senile lymphedema is most often associated with only one of these is a correct answer. Unilateral distribution, extended dermal backflow, a younger age than lymphedema tarda, distal lymphedema clinically, or is this simply none of the above? Good. You can see a lot of you read the paper. Outstanding. Yeah, the correct answer is actually distal lymphedema. And that's usually both from a lymphography standpoint, but more importantly, it's from a clinical standpoint. It's distal lymphedema. All right. So with that, I think this is a great way to open up this presentation is to review an actual real case of mine. This is an 88-year-old male. This is actually a very alert previous attorney who had no pre-morbid history of lower extremity lymphedema until about 2 years prior. And then now he has this persistent, rather severe, as you can see, bilateral lower extremity lymphedema. He wasn't that obese. BMI was 32, no edematogenic meds. From examination, there was no systemic disease. You can see the edema as referenced here. This actually pitted up to about the upper third of the calves. His venous duplex ultrasound really was unrevealing. All the labs were completely normal, including tumor markers. He had a CTB, his abdomen pelvis. It was normal. The echo was normal. More importantly, there was no evidence of cancer, right? Because when you think about when you see an elderly patient with new onset lymphedema, you're supposed to exclude cancer first and foremost. So no cancer. So with this patient presenting to your office, what's the diagnosis, right? So we have an exhaustive evaluation for secondary causes of lymphedema, and it's normal. So would you label this patient with late onset primary lymphedema, also known as lymphedema tarda, although knowing that most cases of lymphedema tarda present after the age of 40? Some would even say after the age of 30. And because of this, and this is why I love this article, is I see a couple of these patients per year that come in as an elderly patient and they look just like this. And I'm always uncomfortable about labeling them with lymphedema tarda because it's just not your typical lymphedema tarda case. So with that background, let's see how this article can shed some light into this clinical entity that I'm describing. So from an objective standpoint, it was to evaluate the Icgl findings in lower limb lymphedema to ascertain whether there is a pattern to age-related deterioration in lymphatic function. From a method standpoint, 56 patients, 104 edematous limbs. Other causes of edema were excluded, like we did in my patient. The BMI was less than 35, so of course that would exclude at least 95% of my patient population. The lymphedema onset occurred after the age of 25. And then finally, the lower extremity lymphedema index was calculated. If you're interested in how that's calculated, it's in the paper. I don't think it really helps from what we're trying to determine here. And let's review some of the key demographic and clinical characteristics. First of all, this is with the entire group. It was an elderly group as a whole with an age of 73. Like most cases of lymphedema, the majority of these patients were female at about 63%, not a large population. BMI was only 26, not real life for the US. Very important point here. 86% of these patients had bilateral lower extremity lymphedema. Remember that. And the duration was only about 5 years. And from an ISL stage, about half of these were stage 1. About a third of them were stage 2, and the remaining 15% were stage 3, consistent with elephantiasis. Now, here's where things get a little bit more interesting from some of the demographic and clinical characteristics, according to whether or not you looked at the bilateral or the unilateral patients with limb swelling or lymphedema. Keep in mind, 86% of these patients had bilateral lower extremity lymphedema. And here's where they differ. It's very, very interesting. I'm going to get this off my screen here. From an age of onset, the patients that had bilateral lower extremity lymphedema were significantly older, with the mean age of 76, versus contrast that with the unilateral group, only an age of about 50. Highly statistically significant difference between the two. Duration of lymphedema was also interesting. In the patients that had bilateral lymphedema, this 86%, they only had lymphedema for about 4.5 years. You contrast that with the unilateral group where they'd had lymphedema for at least 8 years. So about double the amount. Didn't quite reach statistical significance, but clearly it was getting close. And then finally, this lower extremity lymphedema index was significantly lower in the patients that had bilateral lower extremity lymphedema versus the ones with unilateral. The higher the lymphedema index, the worse their lymphedema. And here was an interesting slide looking at the Icgl lymphography patterns. Let's just divide this into the 4 that are seen in the bilateral group versus the only one that is seen in the unilateral group. The first one is the linear Icgl pattern, and this linear is just defined as the contrast begins at the injection site, goes up in a linear uniform pattern and empties into the superficial inguinal nodes. We have a LE or low enhancement pattern, and that's where you can see the enhancement only is occurring in the foot or the ankle. There's no enhancement, contrast enhancement in the rest of that limb. Then we move on to the distal dermal backflow, and Tom had referenced this. You can see this characteristic contrast blush of contrast into the dermis, and this was distal, that was defined as the knee or lower. Then as things became more severe, you have an extended distal backflow pattern where you see it above and below the knee. And finally, you contrast that with the unilateral Icgl pattern where you had also extended distal, extended dermal backflow. And really, there's no difference, obviously, between the extended dermal backflow and the unilateral. It's just one's occurring in the bilateral patients, one's occurring in the unilateral. So that's pretty self-explanatory. And I just referenced this, and I want to say it again, that all cases in the unilateral group showed the dermal backflow pattern in both the thigh and the lower leg. All cases of unilateral, so that's important. So then let's compare the Icgl patterns via age and sex. And again, let's divide this into our 4 patterns seen in the bilateral group versus the only pattern seen in the unilateral group. And of interest, both the linear pattern and the distal dermal backflow pattern were the most commonly encountered Icgl patterns in the bilateral lower extremity group. From an age of onset or age standpoint, as we already referenced clinically, the patients that had a bilateral pattern were significantly older than the ones that had unilateral. And let's go down and look here at the bottom from an age standpoint. This is noteworthy, that there were only 2 patients that had bilateral lower extremity lymphedema less than the age of 50, versus all but one of the patients with unilateral lymphedema were less than 50. And that's an important point between these two. And let's just say, for instance, you look at the age 70 to 79, that's where the preponderance of the patients with bilateral lower extremity lymphedema were present. And there was only 1 patient with unilateral lymphedema in the elderly population. And here's just looking a bar graph looking at the lower extremity lymphedema index in reference to these 4 patterns. And as you can see, as you move through these patterns from linear to low enhancement to distal dermal backflow to extended dermal backflow, unilateral, that this lymphedema index increases. The higher the lymphedema index, the worse the lymphedema. And you can see here where there are statistical differences between a lot of these. So as we start to conclude here, what does this all mean? Well, first of all, age-related deterioration in lymphatic pump function rather than iatrogenic obstruction or a genetic abnormality, which signify traditionally lymphedema tarda, is likely to account for the characteristic older age at onset of bilateral lower extremity lymphedema and its progression from the distal region. These patients with late onset lymphedema, it tends to be bilateral involving the feet and toes. Animal studies have shown that aging collecting ducts have decreased contraction frequency, systolic lymph flow velocity and pumping activity, and lymphatic vessel density and complexity. And there have been several studies showing that lymphocentigraphy and Icgl lymphography, such as this one, have demonstrated a reduction of lymph drainage with increasing age. So finally, let's put it all together and look at this from a conclusion and a clinical standpoint. When you encounter a patient that has unilateral lower extremity lymphedema, it's typically going to be at a younger age, around 50. And also remember on that one slide, 7 out of the 8 patients were actually less than 50 years of age, but it's a mean age of around 50. And this is your traditional lymphedema tarda group, and this is what it would look like clinically. These patients have a higher lymphedema index, signifying they have worse lymphedema than these ones that are presenting later in life. And here's a characteristic Icgl pattern showing the extended dermal backflow pattern involving the thigh and the calf. And then there's also another example of a patient of mine with lymphedema tarda. That's what you expect to see. You would expect to see dermal backflow up in the thigh because the thigh is swollen. And finally, where I find this article is so interesting is finally, I now have an explanation for these several patients that I see per year in my practice that present with a relatively short duration of bilateral or extreme lymphedema at an older age. Remember the mean age was around 75. And this new term now is age-related, or the unwoke term would be senile lymphedema. They generally have a lower lymphedema index. They're more likely to have either a linear or a distal dermal backflow pattern on Icgl, and this is exactly what they look like. It's significant distal involvement. And it's also interesting, it's not relevant to the paper, but when I see these patients, this is what they manifest. It's usually pitting lymphedema. It's often rather severe for the duration that they've had this. It's just a fascinating entity. And now, why are they pitting? I don't know. It could be the fact that the duration is less, so they have an earlier stage where they don't tend to pit, but yet it's somewhat contradictory because even though it's an earlier stage, there's usually a lot of copious pitting edema in these patients. So very interesting entity. I find this very, very fascinating because, again, I finally feel like I have an explanation now for this cohort of patients that I see that I'm always worried about cancer. But yet, I mean, I've seen these patients, not that I've worried, they go on and get PET scans because everybody's worried they must have cancer to have this severe of lymphedema suddenly presenting in an elderly patient. But it may just simply be related to this a senescent degradation of the lymphatic system with time. So that is it.
Great, Steve. Very interesting paper.
Steve, can I ask you a question about your patient? Leave that slide up. Can you?
Yeah, sure, absolutely.
So what are the pigmentary changes right here in the patient's skin? What do they indicate?
No, there's probably an element of chronic venous insufficiency. Right?
Okay.
There's like a little bit of stasis papillomatosis on the right side, but obviously not explaining, well, why does the left side have just as severe as well?
And could you pinch any skin on the toes?
There was a modest amount. It was one of those mildly positive stemmer sign, as I would call it. You could pinch a little bit. It wasn't completely flaccid, but yet it wasn't completely incompressible.
Sure. One of the things, this type of ICG study is totally different than the one I presented because it only demonstrates the superficial dermal area, whereas with the NERFLI, one can see the lymphatic vessels. So that brings up my question. Well, what do you think the status of these lymphatic vessels are? With lymphedema tarda, they're usually, at least from lymphangiography, they're reduced in number. There's hypoplasia. You think that the number is normal, but the pumping capacity is abnormal? What's the mechanism for lymphatic dysfunction?
I think you have, not that it's known, but I think you have to assume this is occurring predominantly at a small vessel level, at a lymphatic capillary level, for instance, where you see the oxidative degradation of the very small lymphatics. It's been shown that, for instance, they start to lose their endothelial nitric oxide synthase activity in the very small lymphatic vessels. The endothelial glycocalyx becomes impaired in the elderly patients from a lymphatic standpoint. So I think it's probably at a small vessel level, but regardless, it's still causing these characteristic dermal backflow patterns that you see, even if it's at a small vessel level. But your point's well taken. Until you visualize the deep system, I guess we don't know. But
No, you don't. It's the superficial system. The deep system's totally different. The changes are in the superficial lymphatic fronts.
Yeah, but even at a superficial standpoint, it's still enough to cause this to get this much edema. So you would tend to think there's got to be some impairment of maybe the deep system is just not the propulsive capacity is impaired to get this much edema. I would just have a hard time believing only superficial lymphatic compromise would cause that degree of swelling. And that's what they typically look like, and they all pit.
But why are you surprised? I mean, a lot of the patients, at least in the literature, even on the venous side, the majority is superficial disease. It's not, even venous ulcers. The most common problem is saphenous reflux.
Yeah, and I guess I'm thinking in those, assuming they're not morbidly obese, they usually don't have necessarily a lot of swelling, even with some of these stasis ulcers. Now, morbidly obese, that's a whole different population, and I think their deep system's impaired for other reasons, not necessarily reflux.
I found
Point of clarification. When we're talking about superficial and deep, the abnormalities in the lymphatics occur in the superficial lymphatics, not the deep lymphatics. The number of lymphatic vessels and lymph nodes in the superficial vessels are really where, in primary lymphedema, it's either aplasia or a reduced number. And similarly, in patients with CVI, we see abnormalities in the superficial lymphatics, not the deep.
Well, but let's just say when you see your typical lymphocentigraphy on somebody that has Milroy's, for instance, you don't visualize the deep system as a whole. You're not seeing it.
Well, in Milroy's, you don't hardly visualize anything.
Yeah, and, exactly.
I'm going back way before we had lymphscintigraphy. When I worked with Professor Kinmouth, we used to do lymphangiography, where you would put dye in and you would just see nothing.
Yeah. Well, but even then, I'm just going back to lymphoscintigraphy in patients that have advanced lymphedema. You don't see the deep system as a whole. If you do, it's dilated, it's segmented, just like it was in your paper.
Okay.
I found it interesting that, obviously with this group having a lower BMI than typical, you would think usually these patients are obese and you account that as part of their bilateral edema. So it's interesting with a lower BMI, that's still in this older population, you still can get non-vascular, non-venous causes of lymphedema. Do you see, I occasionally see, I agree. This is a great explanation for a lot of the patients that I see too, where they show up and then you start looking CAT scans, you're asking them about weight loss, trying to rule out any malignancy, which I think still is important to rule out and not miss. But
absolutely.
I do still see occasionally patients with unilateral disease, short onset, a year or 2 years. You work them up, no real cause, no obstruction, no venous disease. So do you think, an elderly patient, so do you think this could be a unilateral presentation? I know there was a small number of patients.
Yeah, I would say based on all this, but there were only 2 patients out of the 52 that were elderly with unilateral disease. So it can occur. The answer is yes. It just makes you suspect. And I would say it's interesting. I've had a couple of these, this is all anecdote, that are in the same presentation you've had, and they did end up having cancer that was uncovered on a subsequent cancer or a subsequent CAT scan. For some reason, it didn't show up on their initial CAT scan.
A couple of questions from the audience. What is the mechanism for lymphedema in the linear pattern? Yeah,
that's, if you'd read the article, there is no explanation for that whatsoever. Maybe Tom has some insight in it. I thought maybe it had to do with if they were quantitating the duration of the contrast. Maybe that's how they're coming. Because if you would think linear sounds like it's a normal pattern. But I don't know, and I even went back and read one of the same group. They had a previous study from about 4 years ago, and unfortunately, they didn't look at the linear pattern. That was the one thing they didn't look at. So I just have to assume it must be a quantitative decrement in the propulsion rate. I don't know how, because it's not in the paper. It doesn't explain it.
And then there were a couple of questions about the age, the activity level of these patients, elderly patients where they're sitting in the recliner, mostly non-ambulatory.
Not in the methods. That's a good question. Yeah.
What about recurrent subclinical infections damaging the lymphatics in this group over time?
It's a possibility.
And then the last question was, theory-wise, for the patients that have more pitting edema and no fibrosis, do you think it's age-related, that maybe they're not developing fibrosis? Or is it just that it's early onset, you think?
Yeah, that's why it was I referenced earlier. I don't know, but I would just surmise it's just related to duration because they were not significantly, but almost significantly more likely to have the duration was significantly less. It was about half that of the unilateral group. So if they'd only had it for 4 years, you could surmise that's why. I mean, it was early, but yet, see, even there's a paradox there that I find is that they pit, but yet they still have they have a lot of interstitial edema. It's not like it's not your typical lymphedema tarda. The consistency to it is completely different. If you were to see this, the first thing I would think about it would be some type of low protein state like nephrotic syndrome or heart failure, but that's not it. And it's a consistent pattern that I see in these patients.
Tom, just a follow-up. No, Tom, a couple of follow-up questions from yours. How many places did the Icg injection were used in that study?
Well, you use it at various anatomic locations. So at the foot level, you're using anywhere from 3 to 5, and then you go up to the thigh and you use 2.
All right.
I was going to ask Steve, do you think the lack of fibrotic response is related to the inflammatory response that may be blunted in older people?
Oh, wow. Well, that's a great theory, Tom. I'll add that to the possible reasons. That makes a lot of sense.
Well, that's why we don't react to the new COVID vaccination
That's right.
vigorously as the younger injector.
Yeah. Well, let me just put this back to you, then we'll go on. Obviously, poor Tony. Is it? Have you all seen this? Because I see these patients.
Oh, yeah.
That's why I'm so fascinated by this article. Has anybody else? If you've seen it, please send a message because to me it's a real entity. So. Well,
I'm glad you presented it and brought it to our attention. It's a great study.
Yeah. No, definitely. I mean, I do see it, and like you said, the first thing I start thinking is because they're age 2 is, they have no venous disease. So now, they're not in heart failure or anything.
Exactly.
And you start thinking about malignancy and they get crazy and stuff and you tell them that. So, no, it's good. All right. Which brings me to the last paper of the night, and then we're going to play cards. And this is a study from Tom Maldonado. It's out of the VA system. It was published in the Journal of Vascular Surgery, Venous and Lymphatic Disorders last year, and looked at changes in the quality of life before and after use of an advanced pneumatic compression pump in patients with lower extremity lymphedema. This is actually an interim analysis. It was a multi-center VA study, prospective, single arm. So there's no comparative arm here, and it's an observational study. It included patients with both primary and secondary lymphedema, and they were both unilateral and bilateral. And these patients were evaluated for the year prior to use of a FlexiTouch, and then 1 year follow-up with the use of a FlexiTouch. Started in February 2016. Enrollment ended in March of 2019. And like I said, this is an interim analysis of the data. This is a list of the exclusion criteria, which they mentioned, active cancer, infection, thrombosis, the typical exclusions that you would expect in this type of study. The protocol was basically patients were followed in the office. I'll go over the office visits, but the patients were given a diary, which they completed daily as far as compliance of use of their therapy. And they were subscribed at least 5 days of 45 minutes each treatment using a FlexiTouch for each limb. Clinically, they were also given elastic compression garments to be used daily and typical, proper skin care. And then they were defined as compliant if they were using the device for a minimum of 5 days, partial compliance if they were using it 3 to 4 days, and non-compliance if there were less than 3 days of use. This is the clinic visit follow-up protocol. and they were followed out to a year. Their visits were included physical examination, vitals, compliance evaluation, looking at utilization, healthcare utilization related to lymphedema and venous disease. They were staged for the lymphedema, and then they had limb circumference measurements at the calf, 18 centimeters from the floor, and in the thigh, 10 centimeters above the popliteal fossa. They also looked at quality of life measures, including generic quality of life, SF36, and lymphedema specific, out to a year. The primary endpoint was quality of life at 12 weeks, unscheduled lymphedema-related clinics visits, as well as any hospital admissions related to lymphedema complications at 52 weeks. And secondary endpoints included change in limb girth from baseline, as well as change, not chance, but change in quality of life at 52 weeks from baseline. So the total number of patients enrolled in the study is 178. And this is an interim report on 74 of the patients who have already completed their 52-week follow-up. Majority of the patients, about 60% of them, are from Manhattan VA and about a quarter from the Brooklyn VA. And when we look and review at the demographics of these 74 patients, you can see elderly, not surprisingly for a VA system, 67 years of age on average. 94% of them are male, not surprisingly. Some similar to Tom's paper, patient population obese, 32 BMI. Lymphedema stage, lymphedema type, over 95% were secondary lymphedema. And the etiology in this was over 70% of it was chronic venous insufficiency. Bilateral, again, similar to the earlier paper, now over 90% of them included, had bilateral disease. And when you look at lymphedema stage, about 70% of them had stage 1, 27% stage 2, and only 3% stage 3. So earlier stage overall of disease in these patients. 18 patients out of the 74 had a previous episode of cellulitis the year prior to this study. And when you look at the BMIs, a third of them had less than 30 BMI, a third of them between 30 and 35, and a third of them over the 35 BMI. So the majority of these patients, like I mentioned, had a CVI as the secondary cause of lymphedema. And you can see, surprisingly, none of them had superficial disease alone. The majority of these patients had mixed disease, so both superficial plus deep, and a quarter of them had about deep system only. Of note, only about 60% of these patients had a diagnostic ultrasound available or performed. So some of these patients were classified with venous, but I'm not, with no ultrasound. So one of the limitations of the study. But 20% of these patients had a venous procedure previously to enrollment. When you look at compliance, it seemed to be a very high compliant group. Again, they had pretty rigorous follow-up. And over 80% of them used elastic compression stockings. Although they don't define in the paper what is compliance as detailed as they did with the use of a FlexiTouch. But when you came to Flexi, over 88% of the patients used it at least 3 times, so they either were compliant or partially compliant. And only a little bit over 10% were non-compliant. When you look at limb girth evaluation, there was a significant drop from baseline to 12 weeks. And then it kind of plateaued and stayed steady with no further significant decline out to a year. When you look at the primary endpoint, which was quality of life at 12 weeks, there was no significant difference from baseline at 12 weeks and 24 weeks, but there was a significant improvement in quality of life at the physical component of the SF36 at 52 weeks. And similarly, in the lymphedema-specific quality of life questionnaire, there was no difference between baseline at 12 and 24 weeks, but there was a significant improvement at 52 weeks. Looking at cellulitis complications or between the two in this group, the year prior to enrollment to the year after enrollment, there was 18 out of 74, like I mentioned earlier, patients had an episode of cellulitis. And then at the time of use of Flexi, only 6 out of 74, and that was statistically significant. Similarly, cellulitis events was lower, as well as clinic visits related to and hospital admissions related to lymphedema complications. So in conclusion of the paper, they basically significant reduction in limb circumference at 12 weeks, although it plateaued and did not have any further reduction out to 52 weeks. There was continued improvement of the quality of life, although it wasn't significant the first 2 visits at 12 and 24 weeks, but it did become significant out to a year. And the second thing was the cellulitis, significant reduction in cellulitis in these patients, which may explain their improvement in quality of life. So I found a few limitations that I listed here. Again, this is an interim analysis, 74 out of the 170 patients. So it would be interesting to see if the quality of life improved, as it was one of the primary endpoints at 12 weeks once all the patients get analyzed, since we only have about a little bit over a third of them in there. It's non-randomized. It's an observational single-arm study. In this group, there was a very high compliance, both for elastic compression as well as the Flexi Touch. So we can't really tell what really improved or what really caused this, although we have data that has shown that Flexi does reduce, from a payer perspective, data does reduce cellulitis episodes as well as overall cost in the healthcare system. This is mostly predominant male population. And in 40% of the patients, we really didn't have a cause of the lymphedema, although based on Steve's paper, we may have, a significant number of these patients may be related to age-related lymphedema. There's really no data on their SEEP scores that was reported in the paper, so that would be nice to have. And over 70% of the patients, or 70% of the patients had early lymphedema and bilateral. And there was no real cost analysis performed in this specific study, although it wasn't part of the study. So things to think about as far as limitations are there. So with that, I will open, I think there's a bunch of questions here, but if you guys, let's see. Tom, you have any, or Steve?
Yeah, I have a question. Why do you think it took a year to show the changes in quality of life?
So, I mean, and they discussed this in the paper, and it's, theoretical, I guess, but it makes sense. The quality of life, especially the lymph quality of life, is maybe related, the improvement may be related to the fact that there was less cellulitis with compliance of therapy overall, and that may contribute to the improvement in the quality of life in these patients. Because in one of the comments, which in here is that the limb girth was only a centimeter improved, and yes, it's not a dramatic improvement. Statistically, it was significant, but the comment was this could be discouraging to patients. If that's what they're looking for, this was a secondary endpoint of the paper, the primary, not a primary endpoint. And I think if their overall quality of life and hospital admissions and cellulitis episodes, I think is more important overall in these patients than limb girth. I don't know. What do you think, Steve?
I'm sorry, Tim, I'm answering questions here.
I'm sorry.
I'll jump in there because there are studies with breast cancer related lymphedema showing pretty minimal changes in limb volume are associated with fairly significant changes in quality of life. So this finding is not unusual. One of the questions was, unfortunately, I didn't determine it. Since their physical activity was improved, did they have a change in weight that allowed them, because they're more active to get around, was there associated change in weight? And unfortunately, they didn't do routine.
Yeah, they didn't include that. Obviously, a lot of these is a great study to identify also things that, we should be looking at going forward in future studies. Yeah, reduction in weight definitely would be associated. And there have been studies that have shown, with therapy and compliance, these patients do get weight loss as well, which may improve their activity and may also contribute to their improvement in quality of life.
Did you think the compliance was unusually high?
Yeah, but I've been in a VA system, and some of these patients, especially the venous patients, they tend to be very compliant with their use of compression. So I'm not surprised. More so when I was a resident at the VA, I was surprised how compliant they were, and tend to be more compliant than the patients I have in my regular practice now.
They follow orders.
Yeah.
Tony, this is more of an observation on the paper than a question, although I've got a question too. It's interesting, this is entitled Assessment of Quality of Life Changes, and yet the paper pointed out that of the stage 1 patients, they didn't achieve any improvement in their quality of life, and yet 70% of the patients had stage 1 lymphedema. So it was only that 30% that had stage 2 or 3 that actually had an improvement in their quality of life. If I read that correctly? Is that? Yeah,
and I actually, that's you're correct. And I actually asked Tom this question too, and he was kind of puzzled about it. And I asked him to actually look in detail at the numbers, because it may be overall there was improvement in the whole group, but the quality of life improvement, although wasn't that significant early on, but became significant, maybe dramatic in the stage 2 and 3 patients. And like you said, not as much in the stage 1 patients. That even though it's a small group of patients, the difference must be so significant that it brought the whole group to become significant.
Yeah, if you're at stage 1, the improvement in quality of life probably is de minimis, as opposed, as you said, to 2 and 3, where you can see fairly significant changes.
And that p-value in that, he didn't do a sub-analysis to look at it, but if you look at that 30% of patients, that difference may be so dramatic that it made the whole group positive at 1 year. And again, this is, I'm sure, I don't know the statisticals behind it, but this was powered at 170 patients, and this is only, we would have to wait and see what the final results is of the whole study to kind of get a better idea and do a sub-analysis too of all the group, I don't know.
Yeah, I think a sub-analysis would be very helpful, because they obviously took the data that showed that there was no improvement in quality of life in stage 1 versus 2 and 3. There were significant changes in limb circumference in all 3 groups, but yet they didn't subdivide the cellulitis group or the hospital admissions. I think that would be very interesting to know, because you'd want to know, for instance, was the cellulitis reduced, let's say, only in stage 1, but not stage 2 or 3? Or, in other words, you want to use intervention earlier to prevent irreversible cellulitis susceptibility occurring.
Well, you got to be careful with cellulitis, because is it their first episode or second episode? The incidence of cellulitis in lymphedema patients is anywhere from 11 to 15 to 20% first time around. But once you've had an episode of cellulitis, over 50% will develop another episode.
Yeah. So again, knowing they have this data in these three groups that they've subdivided, it would be very interesting just to see the difference in the three groups.
Questions from the audience?
Some observations by the good Dr. Stanbro and Kathleen Lisson.
Is it coincidence that they were followed? Well, no, the study was designed for 52 weeks, so there was no coincidence of that and the improvement in quality of life.
I might comment that this is a real, it's a pretty extensive follow-up for a therapy trial in lymphedema, the length of time and detail.
Yeah. Well, that's the beauty of the VA.
Yeah.
Why do you think that there was a plateau in limb girth improvement at 3 months? Steve, what do you think?
I just think you've mobilized all the interstitial edema. You only have so much interstitial edema. So I don't know. I just think there must be some critical amounts. You can't get any.
Well, that's a very interesting. And I again, it'd be nice if they looked at by lymphedema stage, because if it's predominantly stage 1, then they're going to have a lower proportion of fat in the limb than 2 and 3. So there's more water to squeeze out of the sponge in the stage 1 than a stage 2 and 3. So looking at that will be very interesting. But I think it's pretty common to hit a maximum amount. It's maintaining that decrease in limb volume that's critical. And that's why you got to wear a compression stocking in between treatments.
Well stated.
Excellent. All right. The rest I think we can answer. Oh, do you guys know any data with a basic pump use, 12-month period, showing these results or no? Is there anything out there? I'm sure you know.
No, I've
Quality of life.
not in quality of life, but even on limb girth changes is not a lot of stuff with, you're talking about an EO651?
Yeah.
Yeah. No, I just know the paper that I wrote with many years ago that followed these patients up for 5 years, not with measurements. Well, yeah, with actual measurements, is that about 3/4 of patients will maintain the reduction over 5 years with lymphedema if they're using a sequential pneumatic compression pump. It was not done with a tactile. This was done before tactile was even born.
Okay. I think that wraps it up. There's some closing slides here. So there's just some upcoming webinar, subclinical lymphatic impact of cancer and cancer treatment. This is going to be on March 3rd with Eva Sevic. And I would like to thank Tom and Steve and everybody for attending, as well as Tactile for putting this educational program together. And we will see you at our next Journal Club next quarter. Thank you, everybody. Have a good night.
Thank you.